now. So this is our last session. I do apologize to everybody for allowing things to get run a little bit over with the break sessions, but we are in our last session. I think it's been a great meeting so far. What I'm going to do is turn it over to Dr. Scolaro. This is combined long bone and articular injury, why it matters, and how to manage it. And we have Dr. Scolaro also out on the West Coast, UC Irvine. Dr. Adams actually got stuck in the OR, I believe, can't make it, but Dr. Sirkin is going to stay on to help out with this session. We have Sue Harding from Penn Medicine, Dr. Chinenye Nwachuku, my colleague from up at St. Luke's, and we have Mara Schenker from Grady Health to round out the panel. So I'm going to stop sharing right there. And John, you should be able to share your screen. And I'll mute myself.
Great, thank you very much, Doc. I really appreciate the opportunity. So I'm going to close things out here, talking about combined long bone and articular injuries, why it matters and how to manage. Mentioned the panel, and I appreciate Michael for doing double duty here to fill in and, the rest of my panel here, Dr. Schenker, Dr. Nwachuku, and Dr. Harding. So I'm going to go through a couple slides just on some principles and a little bit of the thought process with regard to these injuries. And then I have 4 cases, starting with some more benign injuries and then kind of working our way up. And Saka, please just give me a shout out when you want me to stop. I know we're a little bit over time, but I want to respect everyone's afternoons or mornings. So the objectives: identify the anatomic locations where articular injury can occur, especially in the setting of a long bone injury. Outline a treatment strategy when you see these injuries that involve both the joint as well as some diaphyseal portion, and then illustrate some of the techniques through cases to treat these injuries. I think there's 2 main kind of buckets that these fall into, and one of those is the contiguous shaft and articular lesions that we will see in those that are non-contiguous. And I think they can be treated in a similar fashion in some locations, but in other areas you need to kind of break things up a little bit. And so areas where we see contiguous lesions are in the distal humerus, something in the distal humerus or maybe proximal humerus that will have a spider up to the joint surface or involve the elbow joint. The distal third femur, a lot of these more elderly spiral oblique rotational femur fractures will have a minimally displaced or non-displaced injury into the joint surface. Proximal tibia, we see this sometimes. And then the distal tibia, I think, is probably the area that has been written about the most. And, we can get into that debate a little bit if you all would like to, about these rotational injuries distally that will have a minimally or non-displaced posterior malleolus fracture. And so those are probably the ones that we all see most commonly. The non-contiguous lesions are a little bit more uncommon, and in my mind, they indicate a much higher energy mechanism of injury. I think the culprit here, and the ones that are most concerning, are especially in the tibia, when you have a combined shaft and plateau fracture. And these are the ones where my antenna are kind of drawn towards the possibility of compartment syndrome or some sort of neurovascular lesion. And so I think in areas where you truly see no fracture line or area that communicates between 2 bony lesions, that has to raise some concerns, not only for the bony injury itself, but also for the associated soft tissue and neurovascular phenomena which may occur. And these can really kind of occur anywhere. So, and this is just purely my considerations. When I have an articular injury, I first think, does this need to be open, debrided, clamped, or this can be fixed appropriately percutaneously? If it's percutaneous and it's minimally displaced, and the treatment is really driven by the long bone lesion, which has occurred. If it's open, meaning do I need to do an open reduction internal fixation, what would be my implant of choice if this lesion were isolated? And then at that point, then you look at both injuries itself, and can you use the quote unquote implants of choice concurrently for the type of situation you have. And then next, but not far next down the line, is what are the soft tissue and biologic impacts of treatment. And we'd mentioned before, if there are lesions that occur in in the diaphysis as well as in the metaphysis or articular portion, doing multiple approaches and placing implants on multiple surfaces does have a biologic impact. And in a contused and affected limb, I think you have to be really careful about this. And then the last point I have here is, articular injury is commonly addressed first. And the one caveat to that is that if there is some component of the articular lesion which is in communication with a more proximal fracture, then maybe addressing or stabilizing the diaphyseal portion can help you create either a partial articular fracture pattern, a B-type injury, or it may stabilize the limb such that you can appropriately address the articular fracture itself. And so, again, this is not based on any high-level literature. This is just kind of a general overview of how I look at these injuries and think to approach them. In the end, this is principle driven. The articular injury requires anatomic reduction, compression, plates and screws, and in long bones, for many of us, and I think as we'll see, intramedullary nails for the femur and tibia are commonly preferred. Plates are more common in the humerus and forearm, and I think if you kind of keep this in mind, then this will help kind of guide your treatment. So I have a case that we'll get into it for a second, but I just want to open this up to, I did 4 or 5 quick slides on, how I think of these injuries. Any of my panelists want to chime in just with something different, or maybe another thought process that goes on?
No, I think, John, you did a nice job of summing that up. I mean, you kind of got to make a decision. Which part of the operation is harder, which is more complicated, which is more important. And then you have to then pick your implants accordingly and what you're trying to accomplish. And I thought that was a pretty nice summary of how it follows pretty much my thinking when I'm doing these.
Okay. Good. Yeah. Mara or Chinenye or Dr. Harding?
No, I completely agree with what Mike just said. I sort of always look at these, and you may look at a distal femur that has a highly common metaphyseal part with a relatively simple articular split. And when I first approached these, I was like, okay, this is clearly an articular injury. But then as I've gone further along in my practice, I realized that the problem there is, from a healing standpoint, is going to be addressing that long segment of metaphyseal comminution. And so really picking your implant to the part that you think is going to be the issue and giving that the stability that it needs, and then working the rest of the fixation around that, sort of how I approach these.
No, I could echo everybody's sentiments exactly. I think one of the slides that you showed with the asterisk, as far as like what's the pattern, what's the order that you fix things, is very important. Sometimes we have these segmental femoral shaft fractures, let's say, with a component of the femoral neck being fractured. Well, what do you fix first? And I just always feel like you should stabilize, the long bone first, because it'll make it easier for you to take care of, that articular injury. So again, I think you hit all the points exactly.
The only thing I would add, the only thing I would add is to say that, it's not necessarily, we all automatically think about, the absolute need to get the articular surface accurately reduced, but you can't forget in the flurry of it to remember that, if you don't have axial alignment of the long bone component, no joint is going to sustain that well. So you have to just kind of, continue to pay attention to both components and not prioritize one over the other necessarily.
The only other thing I would add is when you're deciding what to prioritize, I think it's important to think about what, if it doesn't work, what's going to be next. What do I not have a good answer for? So, and what do I have? Sometimes you have to treat one a little bit better than the other. And so I'm thinking about if there's a problem with one or the other, where would I rather see a problem? You know, a diaphyseal non-union is not that hard to treat. Metaphyseal articular non-union or malunion could be. So just other thoughts that go through my mind as I'm treating it.
Good. All right, well, I appreciate those, and let's put these into practice again. We'll start somewhat benign and then move on to a little bit more complex. This case is a while ago, and so I apologize. Some of the fluoros were unfortunately archived beyond my ability to recall, but this is a 45-year-old male who was involved in a motorcycle collision. His foot got caught on a curve during a low speed turn, and so he presents with this injury, and this is an AP and a lateral, and he actually was sent from another hospital after he was splinted. And just so that we can have all the information, then I'm happy to kind of go back and forth. This is his AP and his lateral of his ankle here. And so, you know, we mentioned that we see a lot of these distal third, you know, kind of extensions from a more metadiaphyseal or diaphyseal fracture, and they usually involve the posterior malleolus. This one, we got a CT scan and has a little bit more involvement. And so, Michael, since you're on my top of my little picture list here, what are the thoughts kind of going through your head with regard to management here?
Yeah, so this is, to me, this is not that femoral shaft, tibial shaft with the posterior mal. This is a pilon. It's a simple pilon, but it's still a pilon. So I think you have to address the articular surface. And for me, this is just going to be, it's going to get staged by my hands. I'm going to put an X-fix on it until the soft tissues calm down. If the soft tissues are ready on day one, that's fine. When it gets to you, since it's already been elsewhere, that's fine. But if it's not, I'll probably put it in an X-fix. Anyway, and stretch the tibia out to length a little bit better. Anyway, then for me, it's going to be, I'd have to study the CT a little bit more, but most likely a open approach at the joint, and whatever I have to reduce, and it's going to be one long plate.
Gotcha. Are you fixing the, similar to what you published on and mentioned, are you going to fix the fibula at the same time? What's your thoughts on the fibula with your X-fix? Are you going to do that? And then,
yeah.
Okay.
Yep. I would pull it out to length, and I would put, I don't mind making it two or three stages. It's all depending for me on soft tissue. There's people out there that fix it all at once. I'm not one of those people. They have good results. That's fine. I prefer to do it I think it's what you're comfortable with and what you do. If you believe in fixing a pilon all at once, I don't think that's a problem. If you have good results with it, for me, it's just easier. So stage one is external fixation with the fibular plating. And stage two will be the definitive reconstruction of the tibia and the articular surface, most likely through an anterior medial approach on this, but I'd have to study the CAT scan a little more.
Okay. Chinenye?
Yeah, thanks. This is something that, I think X-fix you can definitely utilize, but for me, if there's not too much swelling, it's somewhat a little bit out to length, so I definitely have to make sure I get my length back. But I think most importantly, as was stated before, I want to get that articular surface reduced. So whether it means I have to open it, put some screws from A to P for sure. And also definitely looking at that Shapur fragment, that's something I definitely want to address. But this may be something where I may even do an extreme nailing, but making sure that I address the articular surface first. As far as the approach, I would probably also think about doing some sort of superpatellar nailing. And the rationale is this allows me to hold that reduction. I have residents, so sometimes, we have enough hands, but in saying that, I think it is definitely something that's helpful as far as just maintaining that alignment. But I'll also check the stability of the ankle afterwards, because that would probably let me know if I need to do something with that fibula. So I don't always treat the fibula surgically, but if I do stress it afterwards and I see that there's something going on, whether there's a symptomatic injury going on, or if there's the stability of the ankle itself, and not the tibia, but the ankle itself, it's not being held, my fixation, then I would go ahead and augment my fixation to the fibula.
I think if you bring up a good point, something that's definitely changed in my practice was addressing any of these distal third tibia fractures that has, some sort of articular involvement, whether I'm, especially when I'm using a nail, is keeping the leg in one position and allowing my C-arm technician to be the only thing that's really moving, because there's just so many moving pieces, and utilizing a suprapatellar approach, I think is, obviously it was designed for the proximal tibia, but has a role in treating some of these distal tibial lesions as well. Susan, any thoughts?
I would like to emphasize especially for some of the residents who are watching today, that the decision to get the CAT scan in the first place is something that seems obvious to so many of us, but might not be in some community places, or there's people that would try to tackle this thinking this was simply a comminuted spiral shaft fracture, essentially, with maybe a posterior mal. They'd recognize that, but not really investigate further. And I mean, I see things come to my office secondarily like that all the time. And I think your point is that this is far from that. This is, I agree, a pilon fracture, and the extent of involvement up into the shaft suggests, that your dual fixation might be best served with a plate nail combo. So you're treating it differently, but you have to recognize it for what it really is at its core. I'd also be really careful fixing. I'm not a huge fan of fixing the fibula early on necessarily, because it blocks my visualization of the more important reductions to come. So I'm careful about that.
All right. Good. Mara, I'm gonna hold on, because I'm gonna start you off on the next case just in order to keep things moving. I think we can, we can.
Before we go on though, John, I definitely want to stress something. I've done one of these cases, probably more of a partial articular fracture of the distal tibia, and you fix it, and you tell the patients, hey, you know what, non-weight bearing, 6 weeks, don't do anything. And these patients come back because you're doing these really distal fractures, and you're putting probably multi-axial screw fixation. If they walk on it, this could be an issue too. So I think, even though we're talking about, fixing it, I think weight bearing is something that we really have to stress also, as far as like how we treat these patients post-operatively. Because she failed afterwards, after like 3 weeks, because again, host, she was diabetic, things of that nature. So those are all things that we also have to think about prior to figuring out exactly what kind of fixation we want to utilize.
Absolutely. Very good point. So let's go on. So this is, I saw this injury, and this is something that needed an open approach for the articular surface. I thought, especially with that Shaput fragment involving the ITFL and the syndesmosis. And so again, I apologize for the lack of sequential floors, but I only had what I had on my computer from before. And so I proceeded initially with fibular fixation, and then screw fixation, including a small little mini fragment rim plate at the joint, in order to control that Shaput fragment, which was attached to the ITFL, and then some additional screws. Now, what you can't see here, and what I'll show you on the final films, is that I'd also done a small anterior lateral incision and a plate for the dominant shaft component that had come down over to the medial side. And so, when I said before, in general, I'll do the articular surface first, stabilizing that long spiral that came down into the medial column really set my joint alignment up really nicely. And so that was actually the order of operation was diaphyseal, small open diaphyseal exposure first for that plate, and then came down to the joint surface, and then fixed with an intramedullary nail, and then kept the patient off of it like I would for an intra-articular pilon fracture for approximately 10 weeks is usually about what I'm doing these days. And patient goes on to heal. had some issues with symptomatic hardware, wanted his fibula played out, wanted some of the medial interlocking screws out. And so it had a little over a year and a half or so, I went back and took, some of the hardware out, left one interlocking bolt in distally in case I ever needed to go back and get that nail out. And the patient did really well. All right, any comments? And next we'll go on to a more proximal tibia lesion.
John,
Oh, that's very nice job, John.
Yes.
Yeah, no, that was awesome. You did that all in a single stage, and I assume the syndesmosis was stable once you fixed the Chaput.
It was, yes. I did do an external rotation stress examination, and nothing, no instability.
It's great.
Great.
All right, Mara, here you go. 40-year-old female. We don't have, the palm trees don't provide a lot of leaves. So I can't remember what she was up on her ladder doing something around her gutter or her roof. And she came down and found her leg and had this lesion. And I'll just show you everything. And then I want you to tackle it. So this is her AP and lateral over tibia. And so there is some continuity between the proximal lesion that you can kind of see here and then the shaft, but they acted somewhat separately. These are dedicated films of her knee, and then this is her CT scan, and I'll leave it here. So take it away.
Yikes. Yeah, that joint looks far worse there than it did on the initial AP of the knee. Can you go back to the CT scan? So here, we see a lot of these. We see a lot of these high energy falls at Grady. My thoughts when I look at that shaft are I'm going to have a hard time getting that shaft to heal with just a single plate. And so in my hands, I would do an open, I'm assuming that's just a unicondylar. There's no extension into the medial plateau, or am I wrong?
No, see, it has this, like I said, there's a handful of little spiders. You can see my pointer.
It goes
there's a few little spiders, but they're not very displaced. I mean, you can see on the far left-hand image here, there are some, there's something going on, but it's not very displaced. The condyles, for the most part, are in the space that they're supposed to be, slightly, widened here on the left-hand view, but other than that.
Yeah. So, I mean, I think you have you have a lot of options, but what I would probably do is, if you're going to do an isolated locked lateral plate with a nail combo, I would have to use a 4-5 plate, which I wouldn't necessarily want to do if I'm working it around a nail. And so then another option, which I texted you this yesterday, I've only done it once. You can do bicolumnar plating of the tibial plateau, which is my preference. If that was just in isolation, I would plate both the medial and lateral sides, as opposed to putting a 4-5 locked lateral plate. So you could do medial recon plate. You could do a lateral locked proximal tibia plate. And then I probably would do something similar to what you did on the last one with a small open reduction distally, get your length back, because that's going to be hard to hold the length when you nail it. And I probably would nail that around all of that.
Susan?
Yeah, a lot of what you already said, Mara. Again, the articular reduction is going to be, the focus, and there is a. Can I see the shaft component again for a second?
Yes.
Yeah. And is that the end of the spiral there as well?
Yeah, you can see the like I said, there is some communication, but it's really, you can see the proximal extend, the distal extent anteriorly. And so it almost behaves as if it's two separate lesions.
Yeah. I mean, you could, my first choice on this would be plating of the plateau laterally, and then a nail component. I agree with what Derek just put up. I was about to say that if you use a lock plating on the lateral side, you probably don't need a medial plate separately. I think you can control that fracture with a locked construct. theoretically, you could use plating for your entire repair. If you had concerns about entry point for the nail and what that would do to some of your reconstruction on the articular scan. This involvement of the fracture anteriorly there, so you have to just be very careful with that after you've reconstructed it.
Michael, are you going to do anything with this fibula?
Probably not.
Okay.
Unless it needs it, I probably wouldn't. It looks like not. For me, this is ORAF of the plateau, keeping my screws away from the nail. I don't think you need a locked plate. I think I would just, and then I would do a suprapatellar nail, only because it's easier to stay away from your incision, and I think you can get everything. I think if you want to plate it, I don't think this is such a bad one to plate either. If you go back to the diaphyseal x-ray, because if you're going to plate this, you're going to anatomically reduce that diaphysis, which looks like it's a simple spiral fracture, and put 2 lag screws in it. And your plate is just a neutralization plate on this one. But I like the idea better of I think I would make a smaller incision or after the plateau, leave the screws away. I don't think those cracks on the medial side are that relevant. They're just going to be screws crossing them. The trick here is to put your posterior screws into your plate first, so that you leave your entrance portal for your nail. If you want to use a locking plate, you can, but it would be more just to put unicortical screws in until you could change them out into bicortical screws around your nail. And then I would just put a nail in after I would have a clamp on this fracture. That the diaphyseal fracture, regardless of whether I put a nail or a plate in, just to make everything out to length and easy, so I'm not controlling 3 things at once. I want to be nailing a sawbone when it comes down to nailing this.
So I'm going to show you what I did. Chinenye, you're gonna take the lead on the next one. So I got gifts. They just keep on getting better after this. So Michael's it was such a nice tee up here. So this is what we did. So address the articular component. First, use a submeniscal arthrotomy and made a small cortical window and kind of tamped everything back up, including that posterior depression that I had, and then did exactly that. Used a proximal tibial plate and just used the posterior screws are a little bit long here. And they will get changed out, I promise. But it had a nice reduction of the joint surface here, and then clamped both the proximal, percutaneously clamped both the proximal and distal portion of that, like Michael had mentioned, just to essentially ensure that we were nailing a sawbones, and then kept the anterior screws of that proximal row, and then some of the more proximal flare screws out of the plate. Happy with our starting point, and then nail, and then switch things out and shorten those screws proximally, getting a couple interlocking bolts in proximally and distally. And you see that distal fragment, or the distal shaft fracture, moved just a little bit after the nail had gone on, after we had removed the clamps, but the overall alignment was acceptable, and we left the fibula alone. So this is what our final construct was, and I kept this patient non-weight bearing for I think same thing. Most of my articular fractures I'm still holding off for about 10 weeks or so, 10 to 12 weeks. She goes on to, this is about 3 months or so, and then goes on to solid healing, good function, and similarly had some issues with wanting some of her interlocking bolts and hardware out. She felt that she could really feel that proximal plate bothering her, so we just took out her hardware. But you see a nice joint reduction there, and everything else had healed pretty unremarkably. So any comments? I think that's kind of what we had all spoken about. I think the options of plates and nails, but addressing the articular surface and then stable fixation of the shaft. So some people on this call may have seen this case before, but this is a good one. This is a 23-year-old female, high-speed motor vehicle collision, and Chinenye, this is you taking the lead on this one. But let me get through the info. There's a pulseless upper extremity. She also has some other injuries that we're going to kind of not take into consideration for right now. but she gets stapled and sent to our institution with her pulseless upper extremity, and then initially gets managed. But this is just to show you the injuries. She has a distracted humeral shaft fracture, as well as a distal humerus fracture, a kind of a comminuted ulnar fracture, as well as a segmental ulnar shaft fracture that you can see on the far right hand image there. So kind of up and down the arm. My partner, who was on call, did some initial stabilization, and at this point the vascular surgeons, because the primary work here was the vascular surgeons who took care of her and realigned or kind of rehooked her back up, and then we realigned her upper extremity with this external fixator. And then Monday morning came around and she was stabilized, and she had gotten her subtroch fixed, and her pulmonary issues were much better. And then this is what she has. And so this is her kind of her CT scan of her articular surface. And again, I know CTs are not very helpful, but the just take home message here is that it's comminuted. And so I guess I'll just leave this up, and Chinenye, they tell you that she's ready for anything and everything. And her incision for her vascular hookup is on the medial side, but she now has a perfused limb. She has some sensation issues in the radial and ulnar distribution, but per report, everything was there, likely just contused.
So thanks for this one. So again, any last question? Any open wounds in the arm, as far as the arm or the forearm?
No, everything was closable. This was her staple job from the other institution. So you can see generally where her open wounds were, but everything had been washed and closed. And so right now she just has lateral pin tracks that were made through the open incision. These are. I had one of my upper extremity partners who did this external fixator, and he did it correctly. And so he visualized the radial nerve. I mean, this was done via an open approach, but everything is closed currently. So you have a clean posterior. Actually, the posterior soft tissue envelope is essentially untouched, except for along the ulnar aspect of the forearm where you see a little bit of a shark bite there, but that's closable. It was closed at that point.
Awesome. Well, first and foremost, as far as the external fixator is concerned, for all the residents, I think that's an important point. As far as you want to make sure that you visualize that nerve before you go ahead and start putting pins in, like this is the femur or the tibia. So that's very important. Secondly, the distracting injury portion of this whole case is really in the arm. And given that there was some kind of vascular compromise, you definitely want to make sure that you get that out to length, at least keep it shortened as it should be. So I would actually, in this case, make an anterolateral. I'll stage this first and foremost. That's one. Two, I would use an anterolateral approach to address the shaft. And then I'll come back another day. Given that this patient has, again, a lequinal fracture, he's done the osteotomy for me already. It's a blasted distal femur. I'll come back at a later date and then do a posterior approach, utilizing the osteotomy that was made, probably do a parallel plating, which I've kind of gotten into now. I was never a fan, but I've bought in, fixed the olecranon. And then as far as the ulnar shaft and I don't know if the radius was fractured, I don't think so, but the ulnar shaft, I could always address that during the same time or come back a later day and do it depending on how the patient is doing in the operating room. But even though this is quote unquote a wannabe floating elbow, I would still want to make sure that I treated the distracting injury as far as the limb that was lengthened, which is the humerus. So that would be my first thing to do.
Any other thoughts from the panelists? This is kind of a boatload, but it was kind of a fun case, and I do want to kind of blast through the last one as well. So I'm just going to kind of leave it open to any thoughts with regard to order of operation or kind of how to stage this out.
Yeah, so if this patient's stable, which you said he was, and he has clean posterior, I think I'm making one posterior incision along the entire back of his arm, and then just going, I'm gonna fix the humerus, then go through the olecranon osteotomy, the olecranon fracture if I can, fix the distal humerus, and then plate the entire ulna. And I probably would use a second separate plate for the distal part of the ulna. And I just work through it and try to go from there. I think I would fix the humerus first because it's, I think that's a good idea. We usually work proximal to distal, and that makes sense. So
And Michael, are you doing this in a lateral decubitus position?
prone.
Prone. Okay. Susan?
I would consider nailing the humerus. How bad's the olecranon?
Hold for 1 second. Sorry, I don't know that I have anything better than the image you have on the right-hand side.
Right.
There.
Yeah.
Yeah, so it's not one that you can fix with just a screw. Yeah, I probably would stage it too, unless I had a good bit of my day to be able to do this. I would probably nail the humerus because I would want to fix that from the front. I don't think there's anything wrong with fixing it like through a giant posterior incision that would go all the way down into the ulna, but just from a soft tissue standpoint, I would probably nail that. And then flip them. I also do these prone and work through the olecranon to access the distal humerus, same as everybody else said. Then if I can, I probably would try to put a screw in the olecranon and work some mini frag plates around that, and then do probably a single implant, but I would slide it submuscularly.
You have your 5 other open femurs at Grady that you have to take care of in addition to this one for the
That's right.
Yeah, but there's going to be 5 other femurs tomorrow also. So
That's true. That is
so
true.
I would,
Yeah.
I have no problem staging things, but if we can get it done, I just do it all at once.
Gotcha. All right.
And
Here we go.
the only thing I'd add about that staging versus not is, again, mostly for the residents in the group and stuff like that. This lady came in with a lot of other injuries that you mentioned in the beginning, and you have to be very, very attuned to the idea of how much a person can handle in any one insult. So, surgical time and so forth is always a concern. And if it's usually in a polytrauma patient, I find it to be the better part of valor to, concede to that and stage.
Yeah. No, I 100% agree. The physiologic reserve sometimes in these younger patients, Susan, is something that you just mentioned. These younger patients have this uncanny ability to be okay. And then when they tank, it's like very dramatic. It's like, the anesthesiologist or the critical care specialist, usually the critical care specialists are maybe a little bit more attuned to it, but, people will be watching numbers and they'll do fine. And then once they can't compensate, then they swing really quickly. And so I think that's a good point.
This is obviously a lot of work, even in the best of hands. Your goal has to be to get stability across that injury that had the neurovascular damage with it, and then you can live to fight another day for the periarticular stuff.
Yeah. All right, so let's just see what I did here. So, did a large posterior approach for this and used a 4-5 compression plate on the shaft. Was able to just use the olecranon fracture as my osteotomy, and then you can see the visualization that I had there. Was able to get the joint pretty nicely reconstructed, although I'll just tell you, looking at injured cartilage and contused cartilage, it's sad. I mean, you can see the injury that went into it because it was just so discolored already, and we got all the pieces back together, but it still looked very unhappy. There's my final fixation after the shaft, and the distal humerus part was fixed, and then patient was doing okay from a physiologic standpoint, and then I went and just fixed essentially my functional olecranon osteotomy with a longer plate, and then I just left that minimally displaced distal shaft fracture that was a little bit farther down. I didn't span that area because I couldn't imagine this patient was going to be doing a lot. So this is at 2 months. Things are kind of moving along. The most bone that she's forming is along her MCL. But the shaft was actually okay because we had compressed that pretty well. this was about 3 months or so afterwards. Again, having some, the fractures are slowly starting to heal, but she's starting to get a lot of ectopic bone around the joint. Took her back to the operating room, did an MUA before kind of 3 months to get her somewhat moving, and was hopeful after this. You can see some of I guess it's hard to see, but her nerve function, it's still not completely recovered in her radial and ulnar distribution. So she was getting some clawing and was still having issues with hand motion. And here she is at 5 months. Thankfully her fractures have healed, but now she's, after 2 months after her manipulation is essentially has a almost rigid elbow, just because the amount of ectopic bone that she was starting to form. And I can't remember. Oh, let me see where I went there. I went back and tried to manipulate her a little bit. Again, this is as much as I got. And then after this, took out some of her hardware. And then after that, I think I've kind of lost her. So this was a handful of years ago, but everything ended up healing okay. It never had any issues with infection, but I don't know that her joint function was very satisfying, even after all this, after all the operations that that she got here. So you can see she still has a significant amount of or significant loss of motion here. So
do you guys does anybody in the panel ever do any kind of HO prophylaxis whenever you have these kind of injuries in the elbow?
I don't, and that's only because I'm, especially with open fractures at multiple different areas, I was probably more worried about healing of her humeral shaft or her proximal ulna, and so I didn't. But it's maybe worth thinking about a blast of radiation at the initial time, and then not putting them on some sort of long-term anti-inflammatory. I don't know, does anyone else have any thoughts on that? It's a good point for sure.
You have to be a little careful with XRT the elbow as opposed to the hip, for example, because of how close the beam is directed to the skin. The soft tissue envelope is more at risk as a result. So
I stopped prophylaxing my elbows. I just let them move early. The one comment I'll make, John, is although I had a very similar case early in my career, and I did what you did. I plated the humor, I did everything, and I left the ulnar fracture alone. And then I had to brace that. And in the end, that was the biggest pain in the neck. And I wish, and so I said, if I have an ipsilateral injury on that, even though I don't think the distal ulnar warranted operative treatment, I would have operatively treated it, because then I can be more aggressive with my rehab and it might hurt a little bit less. I don't know if that would have changed anything. She had a really bad soft tissue injury, this lady. It may not have, but it may have allowed her to start moving a little bit more pain-free if her distal ulnar fracture and whatever type of, even if it was just an ulnar gutter splint or whatever you did to treat that fracture. That would be my only comment. Otherwise, I think you did a nice job. I mean, that was how I would have approached it as well. The other thing I've been surprised at is that you sometimes can get enough mobility from that olecranon fracture, but there's also times where you're just like struggling, and because you really don't want to take there's much, it's much more distal than where a real osteotomy would be, and so there's more soft tissue attachments. But you don't have a choice. I mean, what are you going to do? Make a segmental ulnar olecranon fracture? So, but that's how I would have approached it.
Yeah, it happened to be in a good position for me to utilize.
Yep.
So, Saka, I have a quick question. It's 10:38. You've had a quick preview of the next one. Should we stop and go to conclusion slides, or should I run through the last one?
It's a pretty good case. Why don't you do this? Why don't you just show us the case? Because I think it's an interesting one to see. And then maybe we can just you can just do, go down the panel just to get any opinions if anyone would have done anything differently and why. Okay. And then we'll wrap it up.
Sounds good. I'll just, that'll give us a good time frame. So this is a 23-year-old male, high energy motorcycle collision. That's just about all we have here in Southern California, because gas is really expensive and you can split lanes. And so, we just see a lot of this motorcycle stuff. So this is a patient comes in. This is an isolated extremity injury. And so there is the AP pelvis, and there is the lateral, the UCI lateral or single view of the femur. And here's a 3D reconstructions of the distal femur. The distal femur is open. Everything else is closed. And so comminuted patella, comminuted intra-articular distal femur. And then, as you saw here, subtrochanteric fracture and femoral neck. Neurovascularly, 100% A-OK. And like I said, isolated extremity, so no head, no chest, no abdomen, completely clear. And he's 23 years old, and so was resuscitated appropriately. A patient came in the morning and we're given kind of the green light to proceed. And so, this is just one of those ones where you just have to think about order of operation, what you can tolerate during a day in the operating room, and kind of, how you want to stage this out. So I'll just show you what we did. This is a little bit view of the femur. This is it's not a simple extension into the distal femur, and you can see the air densities from the fact that it's an open injury is the distal aspect of the proximal fragment that had violated the soft tissue envelope. I believe it was anterior lateral, but I can't remember exactly. Again, this is a little while ago. And this is the femoral neck fracture, vertically oriented, slight amount of posterior comminution, apex anterior deformity as we classically see. And so femoral neck, subtroch, supracondylar intra-articular distal femur, and patella. And so we just kind of worked proximal to distal. And Chinenye, I know we talked about ways to stabilize a neck and a shaft. I used a 5mm partially threaded chance pin through a Smith-Peterson approach to kind of stabilize that proximal segment. I utilized some modified point-to-point clamps anteriorly to reduce the femoral neck. We had an anatomic reduction. And then I placed 2 anterior partially threaded cannulated screws across the fracture, which would be subsequently out of the way of any sort of intramedullary implant. And so this was thinking through this and kind of planning this before I started the operation. And then for the subtrochanteric fracture, again, use a percutaneous 5mm chance pin just to control that floating segment, and placed a reconstruction style nail across the subtroch fracture. And so now I have femoral neck fixation. I have plenty of fixation in the femoral neck because I used a pure form of start entry nail. And so now I have, plenty of fixation there. And now I have fixation in my subtroch. And so at this point, I believe we finished for the day, given kind of everything that was going on, and we were going to come back and fight another day for the remainder of the distal femur. I think I just don't know if I had the tolerance to kind of keep going, or if it was a time of the day type of thing. We got a CT scan again of the lower extremity just to take a look at that distal femur. I can't remember if those are the images that I sent you before. Also just checking the position of all our hardware in the neck. And we had, contained fixation within the femoral neck, and we're happy with that. So then we went down to the distal femur and utilized the open approach, or not the open approach, the open wound, and extended it proximally. You can see the soft tissue air density from the wounds that we were utilizing, and then used multiple screws to fix the patella fracture initially, and then multiple screws for the articular component of the distal femur, and had good visualization through the open wound and the fracture. And so we just literally, like I mentioned before, just kind of broke this up into its component pieces, and you did each of these fractures like I would have otherwise done, but just made a small compromise with regard to nail length so that I could have fixation of the distal femur, and then got the patient out to length based on measurements from the contralateral side. And, unfortunately, there was a gap where there was comminution anterior and laterally I had a medial and posterior medial read through the fracture. And then you can see my alignment on the AP and lateral fluoroscopic images there. So these are my final images. Put a more of a neutralization type X plate or mini fragment plate over the anterior aspect of the patella, just given the fact that I had just screw fixation for it previously, and that held relatively well. I was able to close the whole soft tissue envelope. These are my final AP and lateral images showing the reconstruction and I guess metal toxicity, but I was happy with the stability that I had achieved. I probably at some point tried to link the nail and the plate, but gave up just due to the fact that it wasn't going to be that important. The plate was left off bone because of alignment issues. This is what had allowed me to have the proper alignment of the distal femur as matched to his contralateral side. Patient went on, healed his subtroch and partially healed the distal femur. You can see these images are taken, I believe, 9 months afterwards. Patient was weight bearing as tolerated, was walking, but had distal femur pain. And this is what we were faced with when I had a CT scan. I know we talked about inflammatory markers. I ran some, they weren't elevated. He had never had any issues with his wound, so I had a low index of suspicion for infection going in, but I did biopsy it when we went back. But patient had an incomplete union, but well aligned of his supracondylar fracture. And so this is you can see the bone void from the anterior lateral defect that had gone into the metaphysis here. So I went back, biopsied it, curetted it out, took the plate off, and then utilized an intramedullary nail. I took the nail out proximally, kept the anterior screws, and then used a longer nail, bone grafted this, and then put a nail from top all the way to bottom and just literally butted up against those distal screws in order to span the whole zone. You can see that I just used a longer reconstruction style nail proximally, and then filled all the screw holes. And I put one in the most distal, two in the dynamic slot, one proximally, and then one anterior to posterior. And then these are my final radiographs. Sorry about the distortion on the lateral radiograph there, but that's what we got. And then let the patient just continue to walk and move. And this was a handful of months afterwards. And then I just saw this patient not that long ago, actually, and had come back. And so here we are. And this is, I think, total of about 2.5 years out from the index surgery, but healed femoral neck, no evidence of AVN, healed subtroch, healed supracondylar area, and the joint line, which continues to kind of hold itself up. So yeah, kind of a lot. You can understand why this may have taken a little bit longer if we'd gone through everything. So and then here they're radiographs. I have a slight extension deformity in the on the lateral there, and it's he maintains great extension. His motion is actually pretty good. He's a very compliant patient and works very hard at therapy. So a lot of credit is to him as well. So just in conclusion, and then I'll just, we can open it up and finish off with comments about that case or just any of the other ones. Combined articular and long bone injuries are 100% challenging, oftentimes related to high energy trauma. You really have to identify the optimal strategy for each injury and then figure out if there's any way that you can merge the two strategies that you have created, either using, conjoined implants or overlapping implants. And, Michael had mentioned this before, but, figure out what the challenges may be later if you end up with a non-union of one area. And so I do tend to prioritize anatomic reduction of articular surface. And then, if you can restore length, alignment, rotation to a long bone, then dealing with an issue there, either bone grafting or non-union or whatnot, is usually a little bit more manageable. And I think I will finish off on, we talk about these injuries and non-unions and problems healing and stuff like that. And Susan said something that I think is so important, is that the alignment for both the articular injury itself and for the healing of the diaphysis is critical. The alignment has to be right. And if you can get the alignment right, the articular surface, even if it's, beat up from the injury, will tolerate more. And any area that you have problems healing, anyone who does a lot of non-union work will tell you that once the alignment is right, or if you can keep appropriate alignment of the limb, especially in the lower extremity, it aids healing, so much more. And so I think that's just so important. So I apologize, I've talked a lot, especially in the last 10 minutes, but thank you to my panel, and I'm open to any questions or comments that you may have.
No, John, I think you did a nice job. I think the most important thing there is your femoral neck, which is what you went after first, because we don't have a good operation for AVN of a femoral head in the 25-year-old. We can do osteotomies and stuff for non-union, but not for AVN. And I think you prioritize it. And it just, what happens sometimes with bad trauma, you kick the can down the road, maintain your alignment, come back and fight another day and come. And I think your approach looked sound. It's a great case. It's I think that was a nice way to deal with the non-union and the distal femur.
No, thank you, Michael.
I would say the same thing. I was going to say the same thing. Very elegant way of treating all of this, not just at the time of the initial presentation, you had a clear plan, but as you move through it, like the idea to CAT scan, for example, your femoral neck, after you fixed it, because you were going into the CAT scan to get something else. I mean, that might be like, that was just brushed aside as like, oh, we were tired and we decided to work on it another day. But that was really important for people to hear that, because that was a perfect opportunity to look at something and make sure you didn't need to do something more and not find that out months down the road when it was failing or there were interarticular issues or anything like that. So that was brilliant. And little things like that is what makes the difference between a good, an okay outcome and an outstanding one like this. So good job.
Yeah, thank you. Good. All right. Well, I really appreciate my my panel's involvement. Nice job with the cases. We kind of took it from simple to a little bit more complicated, but hopefully for those listening, at least a way to break down some of these challenging injuries and address them in a planned, systematic fashion. So, thank you very much.
All right, thank you very much, John, and to the rest of the panel. Dr. Sirkin, stepping in for Dr. Adams, appreciate that. Yeah, that was great. Great way to end the meeting too. I guess I have to say, I think the topics today were, we definitely got to talk in depth. I think there were some great topics. I think, I know some of you may not, do trauma every day, but I think there were a lot of great principles here in each of the sessions that I think translate. And for those of you, who really, want to dig deep into the trauma topics, I mean, you heard from a ton of really experienced experts and got to see some really challenging cases and situations. So I thought this was one of our best meetings, to be honest, when you think about it that way. I think the case-based format has been working out pretty well. So I appreciate everybody doing a great job with the sessions on that. What I will say is that this is a CME program. I will hopefully, if everything goes well, I'll have recordings up on like on my website at orthoclips.com and the Orthoclips YouTube channel. So that's just free for anyone to view later on. If there's a case you saw, there's something you heard that you kind of just need to hear it again for later viewing and listening, I'll have that available. Don't forget to claim your CME credits and fill out your evaluation. I believe in the program that was sent out, you should have gotten instructions for that. And I want to thank not only all the faculty for taking their time out, all of you for spending your day with us, and the CME staff, of course, for putting together the program. I do have to make a special mention about Chris Rausch. from the CME office. Nobody dots the I's and crosses the T's like Chris. There's like nothing that gets by him. If you ever want to do orthopedic internship, Chris, let me know. You'll never, we'll never have a drop ball ever again. So thank you, Chris. Appreciate it. And thanks to the rest of the team. And hopefully we'll see you next year, maybe a hybrid program or something like that. I think we're hopefully getting back to live programs. So thank you all very much. I guess if anyone wants to say anything, I will take the, you can unmute if anyone has any comments to say, but otherwise we're done. Thank you.
I just want to take a brief moment and thank you, Sako, putting this together with everybody. I mean, it's a tremendous effort, and you do a very good job, and appreciate everything. So thank you to you as well. So another great symposium.
All right, great. Thanks, Tarek. Thanks for your help, and actually for inviting quite a lot of the people on the faculty today. I know there were a lot of contacts of yours, and appreciate that. Thanks, everyone.
Good job.
Goodbye, everybody. Have a good day.
Thanks, Stuart.